Hey, one of the things I wanted to let you guys know is that when I first started working at Hint, you do the onboarding, but then right after that, they teach you how to dress like Zach. And so, you got the t-shirt, and this is my favorite t-shirt, I love direct primary care, and I've had so many conversations where people say, what's direct primary care? Or they even say, hey, I go to a DPC, and I love those conversations because it's one of the things I love to talk about. But what we're going to talk about today is we're going to talk about adding new services. Dr. Workman and I, we are very passionate about this. We got 4 doctors in our practice, and each one of us has a DPC and a specialty that we do. We've got one doc who does Suboxone, and another doc and I, we do health span, lifespan, longevity, and Dr. Workman does eating disorders. It is really fun working with Dr. Workman. She is a wealth of information, knowledge. She's got a practice where she has practiced at the Eating Recovery Center here, inpatient, outpatient for kids and adults. And now she's, for the last 3 years, been doing DPC and her eating disorder specialty. Tell us a little bit about your story. How in the world does that dovetail with DPC?
I love that Dave says that he likes working with me because I know that my patients stress him out.
So I do. Trying to cover for her patients makes me nervous, so I sometimes call her after hours like, Cassie, I don't know what to do for your patient. So
I came to the DPC space probably like many of you as a corporate burnout, and I had left Eating Recovery Center a couple years prior after figuring out that yes, I like caring for eating disorder patients, but I needed to have more of the long span, the lifespan of like following them over time instead of just seeing them when they're really sick. So when I decided to join a direct primary care clinic, my owners were actually really gracious in trying to help me figure out what would that look like in allowing me to bring both just primary care into the space and also eating disorders into the space. And we decided that that had to be kind of in a different differentiation because the care that they deserve is very different and very specialized, and the time that I spend with my eating disorder patients is a lot more expansive. There's a lot more care coordination. There's a lot of other things that I do that we needed to have a differentiation between the two, but it's also become, like someone over here said, that they like the variety. I mean, that's part of the reason why some of us got into family medicine, and so it's nice to have a little bit of mix of those things. And so we were able to kind of do that simultaneously as I joined a direct primary care practice, which was fantastic.
And for me, I have always loved lifestyle medicine. My wife and I, my wife's in the back, she's a mental health therapist, and the two of us, we co-authored a book 15 years ago, a lifetime ago, on lifestyle medicine, talking about exercise, nutrition, sleep, emotional health, spiritual health, and then also what we're learning more and more, how important community is. One of the things that I love about direct primary care is you can do this. You can incorporate this into your practice, and you can really help people live the lives that they want to live. Last year, when Peter Attia's book, Outlive, came out, I loved it because it expanded my view of lifestyle medicine to a longer timeline. And what I've been doing is asking my patients, saying, gosh, what are your goals and values, and what are the things that you want to do when you're 70, 80, 90, even 100 years of age, if we may be so bold to even ask that question. And so that's been a real fun aspect of our practice, and we'll talk a lot about the nitty-gritty. So let's talk about training. What training was required for you for your eating disorder specialty?
So I am a certified eating disorder specialist, which is not very common to my knowledge in the physician space. There's a lot of therapists and dietitians who have that designation, but because I spent 3 years taking care of patients at an inpatient and residential and PHP level, I was able to look into what would that take to actually become eating disorder certified and be a specialist in this based on the requirements put out from IADUP, which is the International Association of Eating Disorder Professionals. And it took going through a lot of different things, including working with this population for a specific period of time. You had to have so many hours. You have to do classes, you have to write a paper, you have to take a test. So there's a lot of certification that goes behind it because IADUP really doesn't want anyone out there just saying like, well, yeah, I work with eating disorders and I'm certified. So there was actually a thing that I had to go through, make sure that I've met all those requirements and I have to keep up on. But because of that, to my knowledge, there's only 2 of us in the outpatient sector in the state of Colorado who have that designation, and it is something that I can say to my patients, listen, like this isn't just something that I have some knowledge about. This is something that I keep up on, and I can treat you in a different way that maybe your primary care doctor who's just taking care of you and doing the best that they can, because we all know we all do the best that we can, and we try to find out whatever information that we can have about something specific, but it's different than I have lots of experience in taking care of you and your specific needs in terms of your medical needs from recovery, your medical needs and complications from your eating disorder in and of itself. And so that really is something that is important and passionate for me to be able to do that and provide that level of care. And that's something that I feel pretty proud of.
Yeah.
Yeah.
And for me, lifestyle medicine has been something I've been interested in for my whole practice. But then I've been listening to podcasts. Does anybody listen to a Huberman or a Tia podcast? And do you realize how long they are? So I don't know about you. I listen to them at 1.5x just because they are, I usually work out and listen to them at the same time. I was talking to a few other people like, yeah, I do the same thing. Except like a month or two ago when Peter Attia's Zone 2 talk came out, you almost had to be, you have a PhD in exercise physiology to understand that one. I listened to it at 1x and 3 times, and I feel like I kind of got the basics now. This is the type of continuing education. I feel like I have to put about 3 to 5 hours of listening to podcasts a week because all of my patients that are interested in this, they ask me, and they're saying, oh, if you listen to this podcast, they'll send it to me. And so then they send me homework. And so I think it's really fun. It's on-the-job training. I think in terms of cognitive training, it's going to help me prevent Alzheimer's because of that. Hey, let's talk about nuts and bolts.
Yeah.
How does your practice operate on a day-to-day basis? What services do you offer? What do you not offer? What's in the clinic? What do you refer out?
Thanks for that question. So from an eating disorder professional and an eating disorder practice, I am me. That's what I offer. I offer my expertise in kind of the medical complications of eating disorders and their recovery. I have a ton of patients that come to me and think, oh, she must be a dietitian, she must be a therapist, she must have all these other things. And while I would love to do that, and I will dabble as much as I can because eating disorders are complex, I actually ask them to have that outside of me. And so I will give them names, I will give them referrals, and honestly, that's a lot of where my referrals come from, is therapists and dietitians who know me and have worked with me in the past. And so they have a team so that we can collaborate. So I have my own family medicine direct primary care clinic, so many of my patients can come in, and it's nice that when my eating disorder patient says, like, listen, I need good birth control, can you do my IUD? And I don't have to refer them out for that, so they have that practice in there. But from a nuts and bolts perspective, my eating disorder patients see me more frequently and more regularly than my primary care panel. So those patients, I try to keep tabs on them and make sure that they come in at least monthly, because I find that when they're lost to follow-up, they're not usually doing well. From that perspective, they have blind weights, they have vitals. I do labs every single month on them to make sure that we're not missing anything. And then I actually collaborate with their team. So most of my therapists and dietitians I work with, and if I don't know them, I'll figure it out. I have them on an email string, and that's how we communicate back and forth, which can be really helpful. A lot of times my patients will go see their dietitian, and then they come see me, and I'll get a message from the dietitian that says, hey, they forgot to tell you that they haven't pooped in 10 days. So can you help them with that? Because while you were talking about something else, they didn't even bring that up, but they brought it up to me. And so that really helps to have that good collaboration so that we can go back and forth in terms of supporting their care and making sure that they have all of their needs covered. And then I can send back to them, hey, we thought maybe it might be really helpful if they added in an extra snack. What do you think about that? Or from a therapy perspective, they really found that talking about this thing was really helpful for them. Can you flesh that out further in therapy? And that way we can bounce back and forth and have kind of good concerted team care.
It's been interesting. We have somehow backed ourselves into a longevity specialty, partly because we started putting on our website, we're interested in medicine 3.0, and we're interested in kind of Peter Attia, and part of that is wanting to have these conversations, and so we started getting more interest in that. And as we started doing it, we realized this takes a lot of time, a lot more time than our typical DPC practice. I was actually chatting with Eric Kroll, I don't know where you are, and Kyle Rickner, and your practices are starting to include this, and so it sounds like it's not just our practice, other places are popping up with this same, I think we've hit an area where there's patient demand. And so for us, we just started off saying, well, okay, let's do an intake, and we offer a workup that we try to customize it for what the patient wants. I actually just got this order sheet. I just show them, I say, hey, these are the things that we do. We do calcium scores, VO2 max. We do continuous glucose monitors. You can do Gallery. You can do body composition stuff. There's a large blood panel. And we talk and say, well, what are your goals? What are your values? And what seems to fit with you? And then after everything, it takes about 6 weeks to get everything back. And then we meet with them for an hour and a half and review everything, and then put together a plan and start meeting with them quarterly. And so that's where we have landed, and I'm sure that we'll probably have iteration 6 coming up in the next few months, but that's how we've been operating. So let's talk about the toughest discussion point, pricing. And first off, I don't know, raise of hands, the DPC docs, are we terrible at valuing ourselves, and do we underprice ourselves? I think, and I don't know if it's just because we come from primary care and we've been undervalued for so long that we both underpriced ourselves. And so first off, talk about pricing for you, the struggles, the iterations. How did that go for you?
Yeah, thanks, Dave. It's fun to meet people where they want to be and how they're helping how we meet their needs in multiple different ways. So that's fun. But the pricing is tricky and it's hard. And like Dave said, I started by undervaluing myself. My very first conversation with how we were going to price this separate panel was really uncomfortable. My owner kept saying, Cassie, I don't think you're asking enough money for what you're doing. And so we started off thinking, well, if we expect that these patients are going to be, let's just say, on ballpark 3 times the work, let's just charge them 3 times the price. And we started that, and we didn't keep it for very long. We decided that the emotional toll, the physical toll, all of the things that went into taking care of these patients really required more work than we had anticipated. So we bumped up our prices, and we went to 4.5 times. And that was what we left it for a long period of time. And every time my owner would come back and say, are you sure you're charging enough? And I said, leave it, okay, leave it. And I looked, I still have people on that original pricing that was 3 times what we were charging at that time. Our direct primary care, I apologize for my voice, you guys. Our direct primary care panel, we increased our prices because over time you need to do that, right? It makes sense in the market, things go up, costs go up, our costs go up, right? So we increased our primary care prices, and we didn't change the pricing for my eating disorder at that time because I was uncomfortable with it. But after a period of time, we realized that there's one other clinic in Denver that offers eating disorder specialty services, and I was the single cheapest eating disorder doc in the area. So I think you have to look at the market in addition to what your cost is in terms of how much output you're putting. And so we looked at the market and we realized that because I was the cheapest one, some of the patients we were getting were like, they were just not my ideal patient, as other people have talked to. And so we were finding that we had become this cheap eating disorder. And so we really decided we have to increase our prices in order to really get the people who really want to do the work rather than they're being forced to do the work by other people. And so it's uncomfortable sometimes, but I've also gotten really comfortable with saying, like, I'm sorry, this is a specialty service and there's a lot that goes into it. And so this is just what I charge. And if you like get me down and sit me down, does it feel like a lot of money? For sure. And also, I can guarantee you that you're getting fantastic value for that cost.
Yeah. Pricing for us, I think we said, you know, we really want to stick with our pricing principles that we have with our direct primary care practice, which are, we want to be as transparent as possible, and we want our interests to be aligned with the patient as much as possible. And so we could have built a package and had hidden fees attached and margin with every different test. But we're like, you know what? We want the fee to be associated with my time, my expertise, and the time that I'm using to stay current. And then all those other tests we negotiate with our partners, like with the Green Mountain Imaging, with LabCorp, with the VO2 Max, and we try to give the best price, and then our patient pays them directly. And so that way I feel like I'm not benefiting and trying to incentivize a patient to do a test that they may or not need. And so that was initially our philosophy. And we ran into the same problem. We underpriced our first iteration, and we started realizing it took a lot more time. And then we also didn't think through like the amount of time that it took to learn what we knew and also to keep up. And so we needed to price that in as well. Let's talk about marketing. How did marketing go for you? Any foibles? What worked well? What didn't work well?
I would say that I'm thankful that my office manager does a lot of marketing for us, and we didn't do a ton of marketing just out of the gate. We had patients that followed me, and I also had a good referral referrals base that sent it in. But I would say the biggest thing that has been helpful for me is meeting in person with dietitians and therapists. And also one of the biggest things was actually having an open house, where those people who were referral people that have sent me patients over the years and also continue to, I just said like, hey, come, sit, see my practice, see what it's like, walk through the rooms, have some Chipotle, and sit around and talk. And it was honestly a great evening where even the professionals in the room were able to like talk about how they did practice and change and back and forth. So a lot of it is word of mouth, a lot of it is my referral base. I double checked yesterday or this morning that I can, if you Google, I'm like 4th or 5th on Google for if you look for eating disorder physician Denver, which is funny because there's 2 clinics. For some reason we're 4th or 5th, but some of the eating disorder hospitals come up further, and I don't know that that's a problem. The other clinic does solely eating disorders, and I do both primary care and eating disorders. So I actually keep my panel to a smaller amount. So I'm not asking for a ton of patients to get through the door, but what I do want is for me to provide quality care for the patients that are sitting in front of me.
Yeah. And for us, I think the marketing has been threefold. One is we spent a lot of time asking patients, what do you want? What is it you're looking for? Because we want to make sure that we are tapping into and delivering on what patients want. And one of the things that we found is that there's really 2 buckets. There's the smaller bucket are patients that are saying, hey, I want to have a workup. I want you to give me the results and tell me what to do, and then see ya. And I try not to take offense at that, but maybe they've got a good relationship with the doctor, or maybe they don't feel like they just wanted to know what's their status. But the 90% are those that would like to do the testing, the workup, the follow-up, and then partner with me every quarter and put together the plan. And I love that because I'm a DPC doctor and I love continuity. We've also, I say Google is our friend. Google advertising, and I've told a number of you, like for our practice, Google ads, well-written Google ads with SEO has been one of our biggest drivers of business. The other thing is, shockingly, Reddit. There is a longevity Reddit chat, and so we kind of engage in that, and that has been particularly helpful. Surprisingly, Facebook has been helpful for the doc moms groups. Yeah. Doc dads groups, not so much. Yeah. Anyways, we're going to open it up for some questions, but while we're getting some questions, I want to ask you, what have been the biggest challenges about having a DPC and a specialty side by side?
My biggest challenge is energy, and I would say that's actually not only just DPC and a specialty side by side, but also the fact that I have a family and I'm a mom. And so if I have a particularly taxing day, it takes a lot of energy to see patients and encourage them to eat another thing. That can be hard for me to go home, and so I have to really manage that and really reset getting home and showing up. And yeah. I don't know what you feel like has been your challenge.
I think the biggest thing is that some patients sign up for the DPC practice, and then they want everything with the longevity practice. I think they want to pay the DPC price, but they want all the benefits. Yeah. And I'm a softie. I'm like so bad. And so other people are like, Dave, you've got to tell them no. And so I'm getting better, but I think trying to differentiate between the two. And sometimes in direct primary care, since we do so much, that it can be difficult to make that differentiation. And so one of the things that we've been trying to differentiate is if somebody wants the full package and we understand that right from the beginning, we steer them right to the longevity program. But if somebody wants a calcium score and an ApoB, okay, fine. They can be on the DPC practice and I'll add a few things. But I think that will probably be something that we struggle. Do you struggle with that, with the eating disorder?
Yeah, we found some tweaks and little things like, oh yeah, you've been inpatient for eating disorder in the last year. You are not accepted on my primary care panel.
Yeah.
Yeah.
So, questions?
Hi, Dr. Workman, Dr. Cameron, thanks for being here. My name is Rob Miller. I run a food as medicine company called OTL, and so it's really exciting to see everyone talk about lifestyle medicine. And we just started working with a DPC clinic out of the Pittsburgh area, and we've worked with primary care docs, and we really try and come in and offer ourselves as an extension of PCP's teams. And that's been an interesting challenge because I think our mission is internally, how do we care for that patient as much as the doc cares for that patient? We try to assist the practices we work with pricing, serving medically tailored meals, nutrition assessments, things like that. But just wanted to generally ask, what's the best way that a food as medicine company or a lifestyle intervention could meet, the DPC movement where it's at, and really try to kind of be a part of this, rising tide lifts all boats, because the food as medicine movement is certainly trying to take off and make a name for itself, and I think there is an interesting opportunity to pair that with something inside of DPC.
You want to take that?
My biggest thing is get physicians to try it themselves, would be my thought. The more that you show them the value on themselves, the more that they're going to want to refer patients to you. I don't know if you have another great idea.
Well, one of the things I've found is that people feel very strongly about their nutrition plan. I always ask people, I say, and I've got some people that are very plant-based, other people that are very paleo, some people that are very much into whatever, and you know what, I am not one that is going to necessarily, I love to talk to people about their values and their goals, and frankly, I think there's a lot of different ways that you can be able to steer and to be able to navigate through that. I love what you're doing. I think that partnering with docs, getting the word out about what you're doing, and being in places like this where you can be able to tell people what you're doing, tell about your program and how we can partner with you, I love it all.
I really enjoyed the talk. It's spectacular. It's exactly what I'm looking at when I opened my practice in January. So I wasn't sure if you left us hanging or not on your 3 times, then 4.5 times, and I wasn't sure if you landed on 4.5 times, or are you on 5 or something now?
I'm on 4.5 times now. We increased the price a 3rd time because our direct primary care prices went up. And so there was a time where it was kind of in a weird multiplier, but I'm still at a 4.5 times.
Thank you. And in reference to, I'm loving the longevity, lifespan, health span component. I can't wait to include it as a separate service line in my practice. And to your point about dietary, and you're right, people all feel really strong about it. I really like Hyman's approach, which is plant-based, but that doesn't exclude meat or other avenues to pursue. And it's very fascinating. And in my practice, it's been fascinating to see how many of my vegans are vitamin B deficient, ferritin deficient. It's been impressive, and it's no judgment associated with it, just guide them into how to supplement up to their veganism.
Great, thank you, I appreciate that.
This is a great talk, thank you. Quick question for you both. I know there's a lot of mixed opinions, but would love to hear yours. So for those who are also board certified in obesity medicine, what thoughts do you have on how you differentiate the obesity medicine service line when working with individuals with obesity is such a core part of the DPC and just sort of disease management?
I'll take that.
I think for me, there are just certain criteria that makes sense. So if the more that you have rules in place, you can break your own rules whenever you want to, because that's the brilliance of being somebody who works for themselves, right? But I think the more that you have some guidelines that you can say, no, you fit these guidelines, the better off you're going to be. And whether that's the additional support they're going to need, the medications you're prescribing, those type of things.
I think one of the hardest things is when you have a DPC practice open and the specialty practice and patients can choose, it gets tricky for the patient to know, like, okay, what's the difference between the two of these things? And so we've spent a lot of time trying to say, like, this is DPC. Like, we go back, okay, this is DPC, this is the specialty. Now with GLP-1s, it's a little bit trickier now. I think it was a little bit easier with bariatric medicine prior to the GLP-1s, because so many primary care docs are doing GLP-1s as a part of their DPC practice. And I think what I would recommend for you is say, like, okay, what is our differentiator in our bariatric side of the practice? What is the worth of that training, my expertise, the amount of time? Because we know that trying to figure out all these prior authorizations and trying to help our patients get affordable medications can be really time consuming. How do you price that? I think that's the tricky part.
I think the other thing, I know that we're out of time, but I would not knock a meet and greet. There's so many times where I can sit down with somebody for 30 minutes to have them ask all the questions about me, and I get a good sense of where they're gonna fit, and then I will say in that meet and greet, if you're not fitting on that panel, we're gonna move you.
I know we're out of time, but we're gonna be around, so we'd love to chat with you. This is such a fun topic. I've already been talking to a lot of people about longevity. Dr. Workman loves talking about eating disorders. Come strike up a conversation.
Thank you.
Thanks so much.